extremely grateful to Venkat and his team here and the Yashoda Hospitals for giving me this opportunity of speaking about this probably emotional topic which most of you would have faced in the intensive care unit. This is one of the most common problems we face apart from hypoxia and shock in the intensive care unit, and we need to have a very simple, no-nonsense approach for cracking fever in the intensive care unit. So as you know, this session is clinical pearls in the ICU. So let's look at what a clinical pearl is in the context. If you look at most professional societies, you look at the Royal College, you look at the ANZICS, you look at the Chess Society, they all have an annual clinical pearls session in their specialty. Why do they have this? They have this because clinical pearls are beyond guidelines, beyond randomized controlled trials, and beyond meta-analysis. They are small bits of freestanding, clinically relevant information which are based on experience or observation. So it's not all that you read from the guideline and you put it into practice, everything will fall into place. Sometimes you need to extrapolate or mate that guideline or that randomized controlled trial or that meta-analysis with experience which stalwarts like Dr. Vijay Kumar and Dr. Kamlesh would bring to the table. It's also a practical teaching point that is supported by the literature, but generally not well known to most of us who are practicing that field of medicine. At the end of this presentation, most of you will realize that what I'm talking is not rocket science. Most of it is basic common sense, which Dr. Vijay Kumar sir alluded to as the sixth point in his conclusion, but you don't find it in your textbook of intensive care or textbook of medicine. So that's the perspective in which we should look at what I'm going to speak in the next 20 minutes or so. We'll start with one enigmatic case, which I had the opportunity of cracking the diagnosis. This was about 8 years ago. This is a 76-year-old lady who was a non-diabetic and non-hypertensive, admitted to the ICU through the emergency room with fever, agitation, hypoglycemia, atrial fibrillation, weight loss in 6 weeks without any contributory drug history. Now, this elderly lady was thinly built and had wide pulse pressure on examination. Her temperature was 105 Fahrenheit on surface monitoring, and on tympanic membrane temperature measurement, it was 104.3. When I was talking to her and trying to evaluate her, she was trembling in her hands and had atrial fibrillation. Her cardiac auscultation showed no murmurs, and there was no clinical localization for the fever in terms of a pneumonia or a UTI or any other obvious cause of a pyrexial disorder. If you look at her labs, absolutely unremarkable labs for somebody who's febrile, agitated, trembling, and having atrial fibrillation. Hemoglobin of 9.4, fair enough in an Indian context for a 76-year-old lady. White cell count 12,300, normal platelet counts, normal creatinine, surprisingly, normal liver function tests, a CPK which was bordering on normal, at around 1,000, little bit of elevation, 1,000 international units, a negative procalcitonin, and chest X-ray unremarkable, and ultrasound showed no abnormality, and the CUE was absolutely normal. So it's open for everybody. What are we treating here? 76-year-old lady with a hyperthermia, with CNS agitation, with cardiac excitability, with normal lab parameters, no clinical localization. Any guesses? Thyrotoxicosis, fantastic. I doff my hat to whoever said thyrotoxicosis. This was my first diagnosis for this lady when I saw her in the... So this lady, was it meningitis? We don't know, because elderly do not have the typical neck stiffness and all the signs described in neurology literature. In the current context, she came in the same month, I think May, June somewhere, when the temperatures were like this. Heat stroke, are we dealing with heat stroke with that 1,000 CPK? Is it a neuroleptic malignant syndrome? There wasn't any drug history contributing. At 76 years of age, are we talking about an occult malignancy? Anything else? It turned out to be anything else. It turned out to be thyrotoxicosis, and we treated her successfully. So the first clinical pearl, which I can quote from this experience, is that discriminate between pyrexia and hyperthermia, right? The temperature cutoff is 104 in the textbooks, but Between 104 and 105 is where you discriminate between hyperthermia and pyrexia, because once you identify that somebody is hyperthermic, your differential diagnosis narrows down into a few specific life-threatening disorders. I'll show you the algorithm, but remember that once you are dealing with somebody whose temperature is more than 104, by non-surface monitoring, you should be looking at a fixed number of disorders which can be life-threatening if you do not recognize that. That's the first clinical pearl I can allude to. The second one I can quote is that hyperthermia is less common in bacterial and fungal infections. Some of the viral infections, especially those which involve the brain stem, can produce hyperthermia, but that's not a result of the infective process, but that's because of the CNS disconnect by resetting the thermostat. So if you have a hyperthermia, the number of disorders you look at is limited, and you should look at non-infectious causes as equal contributors to the process of hyperthermia. That's the second clinical pearl we can learn from this case discussion, from this case vignette. In elderly people, delirium is one of the first signs of infection and sepsis. So if a patient is delirious, is more than 70 years of age, don't just look at psychosis, don't look at hypoxia and other issues. Look at infection as one of the triggers. Just like you have febrile encephalopathy and febrile seizures, the geriatric patients also present with agitation and delirium as the first manifestation of an infection. So that's one clinical pearl I can quote from what this case scenario has taught me. When you track a patient who is either pyrexic or hyperthermic, use one form of temperature monitoring consistently. That's because each modality, whether you use a nasopharyngeal probe, you use a rectal probe, you use a tympanic membrane, or you use a surface temperature probe, or you use a pulmonary artery catheter thermistor to measure temperature, each one has its fallacies, each one has a fixed range. So when you're tracking a patient and trying to see the efficacy of your therapeutics, use a single standardized mode of temperature measurement. Don't extrapolate a surface measurement versus an invasive measurement and say, I got less on this, so I will take the lesser number, or I got high number on this, so I will take the higher number. Use one consistent, persistent method of temperature management. So this is the algorithm, very famous algorithm, which looks at body temperature and hyperthermia. And if you look at the left screen, the patient management with hyperthermic patients branches off very early in the course of a management of a pyrexial patient, and that's hyperthermia. So if you have a patient who's got a temperature of more than 104, you need to be looking at drugs, endocrines, and environmental factors first. So that is where you branch off and try to focus your diagnostic abilities in that direction. If the patient is non-hyperthermic, then you look at pyrexial and non-pyrexial. Okay. So you look at infectious and non-infectious, which again branches off into community and hospital onset. This is fairly, we're all well aware of this kind of algorithm, but the important learning point here at the end of the first case is that you need to branch off your patients into hyperthermic and non-hyperthermic patients. We look at another patient, which again taught us some hard lessons. We lost this patient though. 27-year-old factory employee was admitted with 73% burns, surface burns, and had AKI when he presented to our ICU. He came from one of the peripheral centers. He had early collagen therapy for the burns. He had an early tracheostomy because he had airway burns, and he stayed in my ICU for close to 73 days. Now, in this patient, on the day 10, he was persistently febrile. He had pancytopenia from day 12, possibly because of the severe burns, which is known to produce bone marrow suppression in the second week. He had shock that started on day 14. He was not in shock despite the 73% burns in the first 10 days, but that started with the febrile course. He had multiple blood cultures and biomarkers done, which were non-contributory, telling us an answer to why he was persistently febrile. But his procalcitonin remained persistently more than 10, and during the course of the workup, the only thing we could get out from all the images we did was a pansinusitis, nothing else. Is it causing the shock? How often have you seen a sinusitis? Of course, forget about the COVID mucormycosis discussion, but how often have you seen a pan-sinusitis presenting with refractory shock requiring vasopressors and renal replacement therapy? I haven't seen one in immunocompetent patients. So, as part of the entire workup, he was having repeated cardiac evaluations, and this is his echocardiographic picture on day 15 or day 16, which shows a vegetation on the tricuspid valve. This is a fungal endocarditis, which is surprisingly, when we reviewed the literature, is more common in burns patients than in other patients because they lose the skin barrier for gram-positive and fungal infections. So he got antifungal therapy. We treated this endocarditis. He recovered from the shock, and he succumbed to a massive pulmonary embolism subsequently on day 72 or 73. We lost this patient. So what clinical pearls can we learn from this case, Vignet? What I have learned from this patient is that surface temperature can be misleading in certain situations, like a burns, for example, right? You may get extremes of temperature when you do surface monitoring of patients with burns. When the patient's burnt surface exceeds 40%, they will be hypothermic on the surface management, but they will be hyperthermic on nasopharyngeal and tympanic membrane measurement. And you should take the tympanic the invasive temperature to see the core temperature of this patient. So you need to understand what are the situations where surface temperature monitoring can be erroneous and can mislead into actually warming this patient, which could be detrimental to the overall homeostasis of this patient. The second pearl which I learned from managing these patients is that even though it was not a contributory cause for septic shock in this particular patient, close to 80% of patients who have a nasogastric tube for more than 2 weeks in the intensive care unit will have nosocomial sinusitis. If you screen all your patients in the ICU who've had a nasogastric tube for more than 2 weeks, 90% of them will have sinusitis. And 50% of this sinusitis contributes to ventilator-associated tracheobronchitis and ventilator-associated pneumonia. Should you treat them is a point we can all discuss, but definitely it's one of the causes of undiagnosed fever in the intensive care unit. The third pearl I learned from cases like this is the fact that high index of suspicion is needed to diagnose infective endocarditis. The classical teaching where we were brought up to suspect endocarditis is fever, murmur, rash, and splenomegaly. Right? It doesn't happen all the time in all the patients, especially those who acquire this endocarditis as part of the vascular accesses and the immunocompromise that happens in the intensive care unit. You may not get a murmur at all. You may not get the rash at all, or you may not get the splenomegaly in these patients. These are acute hemodynamically unstable endocarditis, and the suspicion should be very high for you to be screening these patients meticulously with point of care ultrasound. The fourth pearl I can go back and say we learned from this patient or this kind of patients is that culture negativity does not exclude infectious causes. The best of centers with the most advanced microbiology setup and the most diligent microbiologists report only 60% positivity on first cultures for patients proven to have sepsis subsequently. So keep a high index of suspicion. Look at other collateral manifestations of sepsis like band forms on the peripheral smear and other manifestations of an infective process before you say that because my cultures are sterile, my patient is not infected. As our patient was. Only on his 7th or 8th set of blood cultures we were able to identify Candida parasilosis in this patient. We look at the third case scenario, the last of my series. 54-year-old gentleman who's a diabetic, hypertensive and ischemic heart disease undergoes coronary artery bypass surgery on and comes to us on day 12 with persistent fever, peripheral rash and liver dysfunction. He has pancytopenia on evaluation in the critical care unit and has an exfoliative skin rash. He has multi-organ failure, kidney, liver, coagulation and hemodynamics being the organs which failed. His blood cultures were sterile. Molecular diagnostics were negative. Connective tissue profile was sent because he had a rash with pancytopenia, which was negative. A transesophageal echo was done to rule out endocarditis, which was negative, and a skin biopsy was done. So, any guesses what we are dealing with? Sorry? Stress. Okay. Any other diagnosis? So this patient ultimately was proven to have a transfusion-associated graft versus host disease. So, in our culture, we insist on our relatives donating blood for us, right? Now, when your progeny, that means, or your siblings donate blood, the chances of TA-GVHD increases, right? That's one of these, problems with relatives donating blood. This patient's son had donated blood for him for his bypass surgery, and that was transfused. And this patient ultimately had TA-GVHD, which has a 100% mortality. It has a 100% mortality in literature, right? So the pearls which we can learn, go back and see what this case Vinay will teach us is that connective tissue disorders are not uncommon causes of fever in the intensive care unit, but they are not hyperthermic. These patients are febrile, they will have a rash, they will have active urine sediment, and they may have other manifestations like a cerebritis, like a nephritis or a hepatitis, but they are not usually hyperthermic, hyperpyrexial in the definition of what we discussed. Pyrexia after transfusion should be viewed with caution. There are innumerable reports of transfusion-associated tropical diseases, transfusion-associated hepatotropic diseases, but transfusion-related non-infective complications can also be a cause of fever in the perioperative patient. Similarly, in a perioperative patient, deep venous thrombosis and hematomas anywhere or in the operative site are causes of perioperative fever. The surgeons may not agree that hematoma is the cause of the fever in a particular patient, but a diligent search should be made to exclude deep venous thrombosis and hematoma at the surgical site or in the retroperitoneum for patients who are persistently febrile and are not showing up obvious causes of infection. And use of extracorporeal circuits can mask pyrexia, right? Right now we are using so many extracorporeal devices, right? CRRT being the first what we used. We use plasma exchange, we use heme adsorbent circuits, we use bilirubin adsorbent columns, we use for paraquat poisoning, and we do ECMOs more often now than what we used to do 10 years ago. So once you put a patient on an extracorporeal circuit, irrespective of how efficient that circuit has got an external warming device, the patients will be hypothermic by 2 degrees or 3 degrees. So if somebody is 105, they will only show up as 100 or 101 if they are on an extracorporeal circuit. So use some core temperature monitoring and correlate the patient's clinical scenario with the core temperature to exclude infections in patients who are on extracorporeal therapy. Especially if your patients are on ECMO and a heated humidifier for the ventilator circuit, your nasopharyngeal probe and your pulmonary artery catheter both will show the same temperature as what the ECMO heating device is showing. So it's not the correct temperature. So you should be able to extrapolate this information and use the most appropriate temperature monitoring device for these patients. So I will summate all that what we have discussed into few syndromic approaches. I'm talking from an intensive care perspective, not from a general perspective. If you are dealing with a patient with fever and rash, the clinical pearl which you can learn is that tropical diseases come top of the list, connective tissue disorders are close second, meningitis with meningococcemia is one of the causes, transfusion reactions can present with fever and rash, viral syndromes often present with fever and rash, and in the trauma patient, the obstetric patient, DIC is the cause of presentation with fever and rash. If you look at a patient with fever and altered sensorium, we know that meningitis and encephalitis are top of the list. So CNS infection remains top of the list, but septic shock, heat hyperpyrexia and heat-related disorders, intracranial bleeds including subarachnoid hemorrhage are causes of fever and altered sensorium, especially if the patient has intraventricular blood. Usually they are hyperthermic. So remember that point. Neuroleptic malignant syndrome, we all are aware of this, and serotonergic syndrome. The pressures of current day social life, the use of antidepressants, SSRIs has increased, and the tendency for patients to get themselves overdosed with these medications are very high. So if somebody is presenting with a serotonergic syndrome, one of the earliest manifestations would be a fever and altered sensorium. So keep the drug history as an essential companion for you to troubleshoot such patients presenting to your emergency room. a fever with an abdominal pain and diarrhea. These are not surgical patients, mind you. I'm talking about medical disorders. Clostridium difficile infection, underreported because we don't suspect it very early. Gut ischemia can cause fever and diarrhea and pain abdomen. Pseudomembranous colitis, lymphomas, and of course neuroendocrine tumors like a carcinoid, for example, can present with fever and abdominal pain or fever and diarrhea with other manifestations. So keep this in mind when you're unable to troubleshoot somebody who has a fever and you're unable to give a diagnosis to this patient. Fever with pancytopenia in the intensive care unit. Look at hematological malignancies. Miliary tuberculosis, if it involves the marrow, you will end up with having pancytopenia in these patients. Myelodysplastic syndromes are known in several extremes of age and they should be sought after, especially if you have a hypochromic microcytic anemia with normal iron studies, you should suspect myelodysplastic syndrome. Paraproteinemias, especially anemia, thrombocytopenia, raised DSR, you should look at paraproteinemias. Drug reactions can never be excluded when there is a fever with pancytopenia. Fever with splenomegaly in the intensive care unit. Look at tropical diseases, the whole bunch of them which produce splenomegaly. Infective endocarditis, as I said. Disseminated tuberculosis can present with splenomegaly and fever. Infiltrative disorders like amyloidosis with fever, and leukemias and lymphomas. Rhabdomyolysis, as I said, 1000 is not rhabdomyolysis, it is muscle injury. So the cutoff is 10,000 and above. If you are catching the CPK at the up curve of the graph, patients presenting fever and rhabdomyolysis should be screened for multisystem trauma. We know that. Multisystem trauma in the absence of infection and hematoma is itself a cause of fever. So remember that. Necrotizing fasciitis is a cause of fever with rhabdomyolysis. As I mentioned in my earlier slides, heat hyperpyrexia and heat stroke are causes of fever with rhabdomyolysis. Superrefractory status epilepticus can present with fever and rhabdomyolysis. The muscle activity itself triggers the fever, so don't forget to image or EEG your patients who are throwing seizures intermittently but are not waking up persistently, and polymyositis of infective and toxin-related polymyositis. Iatrogenic fevers are also not to be disregarded. You must have seen a lot of patients with atropine who have 104, 103 fever when you use it for organophosphate poisoning. Antipsychotics can produce fever and deranged. The humidifiers which you use, what are you using, how much temperature have you set? There have been instances of airway burns happening because of inappropriate temperatures having been set on your heated humidifier. So be aware of that. Some antimicrobials can produce fever. To quote, fosfomycin, linezolid are the prime causes of fever in the intensive care unit. Hypercaloric feeds. You give the patients more than 30 kilocalories of feed, they will have to hypermetabolize it. The carbon dioxide generated is high, they will be febrile. And environmental issues, you don't set your temperatures in the ICU commensurate with the temperatures outside. Doesn't happen here in Hyderabad, but in colder climates, if your temperatures, environmental temperature within the ICU is set warmer than what it's outside, your patient's body temperature also will be higher. So to summarize, let's look at the clinical pulse in a nutshell from what we have learned from all this discussion. Fever in the ICU is never a trivial issue. There are multiple causes. You need to dissect it very early in the algorithm to understand what kind of disorder you are looking at. Non-infectious causes also need to be considered with equal diligence in the intensive care unit as you would look at infectious causes, which we all have mastered. And a structured approach usually gives the answer. Break it down into simple syndromes, break it down into simple combinations, and put the algorithm in perspective. I think we'll be able to hit the diagnosis. Thank you very much.